In part 2, we are going to move on to talking about interprofessional care, cancer treatment, and complications of cancer. Cancer treatment targets 3 goals: the goal of cure, control, and the goal of palliation. Knowing the treatment goal will help you as you decide what the patient needs to be educated on, how to communicate with the patient, and how to support that patient. When determining what the goal of that particular treatment plan is for the patient, important factors are going to be the tumor histology and what the staging is, as well as the patient's physiological status. Do they have other conditions that would make it difficult or make treatment options not appropriate for that specific patient? Are there psychological conditions that would impact the patient? And what is the patient desire? Remember, the patient always needs to be an active participant in their treatment plan. Curative therapy would be a therapy that involves surgery, because you want to have the treatment offer that will have the biggest chance of getting rid of the cancer. It may involve some local therapy like surgery or radiation alone, or with a combination of other therapy like an adjunct systemic therapy, chemo, for example. Examples of curative therapy are basal cell carcinoma of the skin. You can surgically remove that lesion, and then they can have several weeks of radiation. Another example would be testicular cancer, which can be cured with a combination of surgery, chemo, and radiation. And depending on what type of tumor and cancer that the patient has will determine the time frame needed for the patient to be considered cured. In considering control as the goal for treatment, those are cancers that we know we can't completely eradicate, but we also know that they are responsive to various anti-cancer therapies, and we can control them for long periods with that therapy. So examples would be multiple myeloma, chronic lymphocytic leukemia. Those would be cancers that would have control as their goal for their treatment. We've got another friend that we're going to meet in this presentation, and this is a 30-year-old male who discovers a lump on his testicle and schedules an appointment with his primary care doctor, in which he receives a diagnosis of testicular cancer. So I want y'all to think back to the first presentation. I want y'all to think about the stages of cancer and what exactly metastasis means. Think about that, jot down a few notes, and then we'll talk about it. So in initiation, remember that's that first stage. That's when that cell mutation is going to occur as a result of a carcinogen, whether it be chemical, radiation, viral, or an inherited mutation. And then remember, the next stage is the promotion stage, right? And that promotion stage is the stage that is characterized because it can be reversed, but it's the proliferation of the cells that have been altered. And then progression is the increased growth rate of the tumor, the increased invasiveness, or the spread of the cancer, the metastasis. And when we talk about metastasis, remember that's when that cancer has begun to travel to other areas through the lymphatic and or the hematogenous routes, most frequently being the lungs, the bones, the brain, the liver, and the adrenal glands. In some cases, the goal of treatment is going to be palliation. We talked a lot about palliative care last semester, and it's essential that you remember that palliative care can occur with treatment at the same time. So while we're trying to relieve or control symptoms and help these patients maintain their quality of life, they can also be receiving treatment specifically targeting their cancer. So examples of treatment in which palliation is the primary goal would be like radiation therapy or chemotherapy focused on reducing tumor sizes to relieve other symptoms related to that, such as the pain of bone metastasis, for instance. One really interesting trend about cancer treatment is now that cancer treatment is being determined by personalized cancer medicine in some cases. And this is when genetic information helps to customize what decisions are made about patients' treatment, and it helps to target what they specifically need based on their genes or proteins that contributed to the cancer in the first place. And so biopsies can help determine whether a tumor has a specific target that this personalized approach would be conducive to, I guess, for lack of a better word. So beforehand, patients all got the same treatment regardless, but we know that everybody's different, and this personalized approach to cancer treatment, when it's possible, can help to improve these patients' survival rate. Pharmacogenomics is another example of personalized cancer medicine, and this involves studying the genomic variation associated with certain drug responses. But again, not all types of cancer can have a personalized treatment option, and it costs a lot of money, takes a lot of time, and most insurances aren't going to cover it. It's something though that is on the upswing, and hopefully will be even more prevalent in the future. And then we have surgical therapy or surgical treatment, which is the oldest form of cancer treatment, and it's able to meet a variety of different types of goals, with the trend now being more pushing towards less radical surgeries than in the past. So the role of surgery for cancer treatment has many different pathways. It could be preventative, it could be diagnostic, it could be palliative, rehabilitative. So there's many different roles, which this slide kind of details for you. And then, of course, surgical therapy, it can be used as a preventative measure for patients that find out that they are at increased risk for certain types of cancers, whether it be a type of colorectal cancer or breast cancer, and they decide that they want to have a mastectomy or they want to have a total colostomy to prevent ending up with those types of cancers. That is a possibility. And then cure and control, removing only as much tissue necessary, letting the normal tissue be spared, is a type of surgical therapy. There's also debulking, which can make chemotherapy or radiation therapy more effective, because what happens is the tumor mass is reduced before they even start having the chemotherapy or radiation, which makes it more likely that it'll be a successful treatment. And then other times it may be necessary for the patient to receive treatment before surgery. So they may need chemo or radiation before they actually have the surgery to help minimize the amount of burden that's on the tumor itself and to improve the outcome. So kind of either way can happen. Supportive and palliative care is going to happen when there is no cure or possibly not a lot of control in regards to the cancer itself. So supportive care would include insertion of a G-tube, placement of a central venous access device, prophylactic surgical procedures to reduce the risk of bone fractures, things that would maximize how the body is functioning, or things that would help with cancer treatment in and of itself. So the debulking of the tumor that we talked about, but in this purpose, it would be to debulk it to relieve pain or pressure. If a patient had a bowel obstruction, a colostomy would be considered a supportive care therapy. Those are just a couple of examples. The role of chemicals in the use as treatment for cancers actually goes all the way back to the 1940s, and that's when something called nitrogen mustard, which was like an agent used in the war, chemical agent, was used to treat lymphoma. But it wasn't until the 70s that chemotherapy was actually established as an effective treatment for cancer. And this anti-neoplastic therapy involves the use of various chemicals. It's really the most common treatment for solid tumors and hematologic cancers, and it can provide for either a goal of cure, a goal of control, or a goal of palliative care. In order to really understand how chemotherapy targets cancer cells, I just want to briefly go over the cell cycle and what happens. So in that resting phase of the cell cycle, nothing is happening, and that's what's considered G0. In the G1 phase, that's a growth phase. In the S phase, that's a synthesis phase where the copying of the DNA happens. And then in the G2 phase, that's more growth. And then the M phase is mitosis. I do not expect y'all to know this for the test. I'm just trying to help you understand how chemotherapy works. So some chemotherapy medicines can kill a cell. It doesn't matter what cycle they're in. Those are your non-specific, your cell cycle non-specific agents, okay? Other types of chemotherapy kill cancer cells only during a certain phase. And those are cell cycle specific agents. They don't work in the resting phase. Cell cycle non-specific chemotherapy, they can kill cancer cells at all phases of the cell cycle. And they work best when they're given in a large dose, a bolus dose that's given over a short period of time. The cells, they don't actually die right away. They may have to go through several cycles of chemotherapy before death will occur. And so repeated doses of chemo are given to continue to kill all of the cancer cells. Whereas with cell cycle specific, those medicines are actually often given more than one time as well. They give chemotherapy, because of it being given more than one time, of course, that gives chemotherapy the best chance to kill as many cells as possible. But they may be given in divided doses or given multiple times. So, for example, they may be given once a day for 5 days or every 3 hours for 4 doses. They can be given as a nonstop infusion versus the one large bolus that we mentioned with the non-specific type of chemotherapy. So chemotherapy is classified by its molecular structure and its mechanism of action. And again, there's the cell cycle and the cell cycle non-specific and the cell cycle specific. And typically both are given in a combination. As nurses, if you are an oncology nurse, you will receive special training to administer chemotherapy. It does pose an occupational hazard. Chemotherapy medications can be absorbed through the skin, through inhalation, and really you should not be handling them without proper training. When you are handling them, you have to wear complete PPE to protect you from any type of exposure. And even when you're handling body fluids of patients receiving chemotherapy, it's considered that for the first 48 hours following that administration, that you still are at risk in handling those body fluids, so you need to take precautions. Chemotherapy can be administered orally. It can be administered IM or IV. IV is the most common, and we're going to mostly see chemotherapy administered through some type of central venous access device. Although, thanks to recent, advances in drug formulation, we are seeing more types of oral chemotherapy agents. We still prefer the IV route as the most common method, however. And regardless of if it's oral or IM or IV, it's still the same risk of toxicity, and you still have to follow the same type of preventative or precautions as far as handling the medications. One of the adverse things that can occur is that chemotherapy is very irritative. I mean, it's a toxic. It's very irritative to the veins. It can damage the skin and the veins, the walls of the veins, and it can cause phlebitis and sclerosis. But if you are using a central venous access device, there's less risk associated with that versus a short-term peripheral IV. There's a lot of concerns when you have a patient that are receiving IV administration of chemotherapy because you know that they're going to have venous access difficulties. You know they're at risk for catheter-related infection and extravasation due to the chemotherapy. So you know that those chemotherapy drugs can get into the surrounding tissues and cause tissue damage. So it's extremely important when you have patients that you're monitoring, you're assessing and observing their access site, whether it is a peripheral or a short-term peripheral line or a central venous access device, that you're assessing that that you're assessing that site and making sure that no extravasation injury is happening. CVAD stands for Central Venous Access Device or Central Vascular Access Device, and examples would include central lines, PICC lines, patients who are having hemodialysis. Those are all examples of a CVAD. These devices are placed in large blood vessels, and they allow for either frequent, continuous, or intermittent administration, and you can administer various types of fluids, chemotherapy, blood, electrolytes. They do require nurses to be very vigilant in their assessment of complications. You want to make sure that you are assessing for any signs or symptoms of infiltration where the IV fluid or the medication has entered the tissue around that device. You also want to be assessing for extravasation, which refers to the leaking of the drugs into the tissue surrounding the vascular device. Additional complications, you want to make sure you're assessing for signs of occlusion because then the fluids aren't going to be able to infuse, as well as assessing for nerve injury and signs and symptoms of infection. There's also the potential complication of venous air embolism. Thrombosis is additional complication. And we're not going to go into a whole great amount of detail for these complications, but I do want you to be aware of what complications can arise because you will frequently encounter these devices throughout your nursing career. When referring to regional administration of chemotherapy, we are referring to delivery of that chemotherapeutic drug directly into a tumor site, whether it be intra-arterial, intraperitoneal, intrathecal, intraventricular, or intravesical. And it allows for a greater amount of the drug to be delivered, a higher concentration with fewer systemic toxicity. Examples again, intraarterial is when you will have this chemotherapeutic drug delivered through the arteries that are supplying the tumor. Intraperitoneal, it's going to be into the peritoneal cavity if there's some kind of metastasis in that area. Intrathecal or intraventricular is going to involve a lumbar puncture where the chemotherapy is directed through injection into that subarachnoid space. And then intravesical bladder is when that agent is added to the bladder by a urinary catheter and it stays in there for 1 to 3 hours. The unfortunate side effect of chemotherapy is that chemotherapy doesn't know the difference between a normal and a cancer cell. So side effects, of course, are going to be the result of the destruction of normal cells. Various adverse effects from chemotherapy as they apply to normal tissue can be classified as acute or delayed reaction or chronic adverse effect. So for acute toxicity, that's going to occur during and immediately after the administration of the chemotherapy, and it could be anything like an anaphylactic reaction, a hypersensitivity reaction, extravasation, or a flare reaction. Cardiac dysrhythmias could also occur. Delayed effects will be more like delayed nausea and vomiting, alopecia, bone marrow suppression, altered bowel function, things that are going to have a later onset. And then chronic toxicities would involve damage to the organs like the heart, the liver, the kidneys, the lungs, and they can either be long-term, that develop during or immediately following the treatment and that they just persist, or they could be effects that occur with a late onset, but maybe they don't occur when actual treatment is being given. And there is a possibility that a side effect could fall into more than one category, such as with nausea and vomiting. Again, treatment plans usually involve a combination of chemotherapeutic drugs. Dosages are calculated according to the patient's body surface area, and various regimens involve medications that have different mechanisms of action and different toxicity profiles. Specific cancers are going to have certain drug regimens that are preferred, and so that's what plays an important role in deciding which treatment to implement. Cancer cells can undergo mutation, which can lead to chemotherapy not being as effective. And so the best approach is to use multiple drugs that are working at different areas in the cells or different phases of the cell cycle to more effectively kill cancer cells. So the patient that we were talking about earlier, his doctor just told him that he has T2, N1, M0 testicular cancer. What does that mean? Can you think back to when we talked about the T and M classification and figure out what exactly that means? Take a few minutes to jot it down. Or look it up if you don't remember. So T2 would mean that the cancer has spread to blood or lymph vessels near the tumor. The N1 means that there is spread to at least one lymph node, but there's not a lymph node present that is any larger than 2 centimeters in diameter. And the M0 means there's no distant metastasis. Okay, so with staging of cancer, there's the T and M, T for tumor, N for node, M for metastasis. T, TX, you can't evaluate. So think big X, like I don't know, can't evaluate. TXO means there's no evidence of a primary tumor. TIS is tumor in situ, which means it's contained. And then T1 through 4 is based on the size and extent of the tumor. NX for node, unable to evaluate. So anything that has an X is unable to evaluate, or either there's no evidence for the tumor in the first one, and then the node in the second one is NO. So NO, no evidence of regional node involvement. N1 through 3 are the number of the lymph nodes that are involved, or either how extensive the spread is. And then the metastasis, X, again, unable to evaluate. 0 or O is no evidence, and then 1 is presence of distant metastasis. Radiation is one of the older treatments as well. About half of all cancer patients will get some type of radiation therapy at some point in their treatment, whether it's for palliative purposes or whether it's to control or cure the cancer. Radiation involves energy being emitted and traveling. So it's the emission of energy from a source that travels through space or some type of material. There's different types that are used to treat cancer, with external beam, that's supposed to be beam, not beam, external beam radiation being the most common. Internal radiation is offered as brachytherapy. So there's two different frequency of the energy beams. There's the low and the high. And for most radiation, you're going to see that high energy beam because it can penetrate the tissue deeper, and it helps as far as targeting the areas, but still able to spare the skin that surrounds it to a certain degree. Whereas the low energy beams, they don't penetrate the distance quite as far, and they're useful more for like skin lesions. The dose of radiation, once it's determined, which will be by the radiologist, it's divided into daily fractions. So the patient will receive treatment once a day for 5 days a week for anywhere from 2 to 8 weeks. So the minimum would be 10 days of treatment. Certain tumors, of course, can be more susceptible to the effects of radiation than others. And the whole process by which they determine what the treatment fields of the radiation are is very specific. They define those areas and mark them out, placing a little tattoo mark almost on the skin so that when the patient comes back day to day, they can get that same specifically marked area. And this is an example of a patient who is positioned on a simulator, which is the diagnostic x-ray machine. And the diagnostic x-ray machine is able to recreate the actions that of the linear accelerator that would occur during treatment, so that they can go ahead and mark the fields that are going to be targeted. So remember that radiation is used to target a carefully defined area of the body. That's the reason they have to be so specific when they're determining the radiation field. It's not a primary treatment for systemic disease, but I do want you to know that radiation can be given systemically. So radiation can be offered via external radiation. When they're using the beam, it can be used through brachytherapy, or it can be given systemically through either an oral route or intravenously. When patients receive these radioactive drugs systemically, there may be special precautions that they need to implement as far as safety measures, because they can have that radioactive material leave their body through sweat, urine, blood, saliva, and so that makes the people that they live with at somewhat of a risk for radiation exposure. The external radiation, again, is the most common radiation treatment. Patients are exposed to radiation from a megavolt machine, and there's different types, gamma knife technology, cyclotron, linear accelerator. I'm not going to ask you to name a type of a radiation machine. I just want you to have seen these words before. That's a linear accelerator. And then the internal radiation, which I do want you to be familiar with the term brachytherapy, is when that radioactive material is implanted or inserted either into or very close to the tumor with minimal exposure to healthy tissue. And again, most effective treatment is going to usually involve a combination. So in this case, a combination of types of radiation, just like with the chemotherapy, it involved a combination of different types of chemotherapy. With internal radiation, the patient is emitting radioactivity, so we want to be considerate of that and limit our time near those patients that are being treated. And you can do that by making sure that you are organizing your care, that you have the equipment that you need when you go into the room, that you're not going in and out multiple times within, a short time period, that you're really planning ahead. You may wear a film badge to monitor exposure, and use shielding, of course, to prevent yourself from exposure as well. Common side effects from the radiation are bone marrow suppression, fatigue, GI problems, skin and mucosal reactions, of course, pulmonary effects and reproductive effects. And it's important as the nurse that you educate the patients about what type of treatment they're getting. So don't get overwhelmed with all the scientific terminology, but if you were to educate a patient, if you had a patient who was getting brachytherapy, then I would expect that you would be able to prepare that patient for that procedure. What are they going to expect? What's going to happen during the procedure? Are there any safety measures that they need to be aware of? Those are the types of things that you really need to focus your studies on. Bone marrow suppression is a potential complication or effect of radiation and chemotherapy. And so myelosuppression is actually the most common side effect of chemotherapy, and that occurs when there are because of the treatment, your red blood cells and your white blood cells end up being reduced, and that can lead to patients being at risk for infection, hemorrhage, and it can cause overwhelming fatigue. So neutropenia is when those patients have a reduced white blood cell count. More specifically, it's looking at not only the white blood cell count, but the ANC, which is the absolute neutrophil count. And a patient has a really serious risk for infection if that ANC falls less than 1,000. These patients are going to need their temperatures monitored frequently. They're going to need their WBC counts and their ANC counts monitored regularly. They're going to need to make sure they report any fever of 100.4 higher to their providers. We've got to make sure they're not developing any breakdown of their skin because that's a source of infection. And if antibiotics are needed, they have to have their cultures drawn prior to initiating that antimicrobial therapy. These patients can have infection but not present with that same high fever or drainage that a patient who had a normal or I don't want to say normal, but you know what I mean, a regular white blood cell count or neutrophil count, they may really be able to show you that they're sick. But these patients, they don't present the same way. For patients that are on neutropenic precautions, these patients are the ones who it's been determined that their results are less than that 1,000 for their ANC count. They're going to require a private room. If they leave the room, they're going to need to wear a mask. No live plants, stagnant water, because that can increase their susceptibility for infection. Frequent hand hygiene, of course, we don't want to do any invasive procedures unless they're absolutely necessary. They should have their own dedicated equipment if that's possible, and they may need white blood cell growth factors if those are prescribed. Additional things, if they're at home, would be they shouldn't change the litter box, they should avoid gardening, they shouldn't drink beverages that have been sitting out for longer than an hour at room temperature, because we know bacteria will start to grow in those. It's important that they wash dishes in hot soapy water, sanitize their toothbrush daily, either in the dishwasher or in a bleach solution, and avoid sharing personal products. Anemia is going to be that reduced blood count, and so you're going to be monitoring hemoglobin and hematocrit. Excuse me. You're going to be monitoring for fatigue, pallor, dizziness, shortness of breath. These patients need education to balance their rest and activity. They may need iron supplements in erythropoietin or darbepoetin alpha, and we'll talk about that again in a second. And you're going to want to encourage foods that can help stimulate their red blood cell production. Of course, you want to be prepared to administer blood if necessary. Fatigue can occur not only as a result of anemia, but also just a universal symptom affecting most patients with cancer. And it's found to be the most distressful because, when you're fatigued, you just can't do anything. So the quality of life is much less. One suggestion to help patients who are fatigued, although it can be difficult to get them going, is to encourage them to participate in some type of daily exercise activity that's within their limits. As a reminder, when we're looking at these hemoglobin and hematocrit levels, your normal hemoglobin for a male is 14 to 18 grams per deciliter, and for females it's 12 to 16. And normal hematocrit is 42 to 52, females is 37 to 47%. And then we have thrombocytopenia, and that is when a patient's platelet count is abnormal. So with these cases, you're assessing for petechiae, ecchymosis or bruising, bleeding gums, nosebleeds, occult or frank blood in stools, urine, or emesis. These patients need bleeding precautions, so avoiding IVs and injections. If they do have a blood draw, then you're going to want to make sure that pressure is held to that site for about 10 minutes following it. These clients need to be handled very gently. They don't need to be taken NSAIDs, and they may need thrombopoietics. So what are some suggestions for preventing their risk for bleeding? You want them to wear closed-toe shoes. You don't want them to have open-toe shoes that would be exposed to some type of potential injury. They need to use cold application for injuries instead of heat, because heat's going to cause them to vasodilate and bleed more. Three pharmacological agents that you should be familiar with are iron, folic acid, and vitamin B12. Of course, iron is used and needed for red blood cell development, and oxygen transport we know is related to the amount of red blood cells and how well functioning they are. So that's an important nutrient. Usually the dose is going to be recommended to be between 150 to 180 milligrams per day of oral iron, and that would be administered in 3 divided daily doses. Iron has a very, very, very significant adverse effect of GI side effects, such as nausea, vomiting, and constipation. It can also stain. It can stain the skin if it's given IM. It can stain the teeth if it's a liquid route. So for IM doses, you want to make sure that you're using the Z-Track, but you hopefully can avoid that route if possible. And then as far as the liquid route, you may want to dilute that liquid iron with water or juice and make sure that the patient is rinsing their mouth after they have taken that medication. The parenteral form of iron, dextran, has a risk of anaphylaxis. So be aware of that and have life support equipment readily available and epinephrine readily available if IV dextran is given. Another tip for the staining of the teeth with the liquid iron, in addition to diluting the liquid iron, is to having them rinse their mouth after drinking the medication, is to have them use a straw when they're taking in that liquid iron. So both epoetin and darbepoetin are pharmacological agents that act on the bone marrow to increase red blood cell production. A major nursing consideration for these agents are the importance of frequent monitoring of blood pressure. We need to know a baseline blood pressure, and we also need to be aware that if these levels rise too quickly, then there's a serious complication of severe hypertension or a thrombotic event like an MI or a stroke. So if you see a patient's hemoglobin and it is rapidly increased more than 1 gram within 2 weeks, or if their hemoglobin is higher than 11 and they're still receiving treatment, then you need to be aware that that complication can exist. Seizures are also a potential complication if that hemoglobin rises too quickly. So if you see a patient and you're noticing this trend and their hemoglobin is rising quickly, you need to go ahead and implement seizure precautions and be prepared. Their hemoglobin and hematocrit should be monitored twice a week until whatever that target range the provider has determined is reached. And it should not, neither drug should be used in patients with uncontrolled hypertension. It's also contraindicated with some cancers due to a potential to increase tumor growth. And the weight is what determines the dose. So assessing the patient's weight is important, as is when you're administering the medication. You want to make sure that you're not agitating the vial. You're going to use each vial for 1 dose, and you don't reinsert the needle back into the vial, and you don't mix any other medications in the syringe. Typically, these patients are going to receive these medications 3 times per week. That's the usual dosage. But the darbepoetin has a much longer half-life, so about 3 times longer than the epoetin, so that may be administered a little less frequently. In regards to fatigue, what nursing implications pertain to a patient's fatigue? We want to talk to these patients, encourage them to rest before activities, encourage them to ask for help with activities. When patients feel better, really encourage them to take opportunity to be active. They need to pay attention to their nutritional and hydration status. Look for what is causing their fatigue that can be reversed. Are they drinking excessive amounts of caffeine? Are they not getting adequate sleep at night? What can we do to reverse those causes that are modifiable? And GI effects, including nausea, vomiting, diarrhea, constipation. You may intervene with prophylactic administration of antiemetics. So these patients may take an antiemetic prior to treatment. You want to be assessing for signs and symptoms of alkalosis, dehydration, making sure you're monitoring I's and O's, encouraging a non-irritating, low-fiber, high-calorie, high-protein diet. They may require anti-diarrheal or anti-motility, antispasmodic medications. If it's a patient who's suffering from anorexia or lack of appetite, really need to pay attention to their weight, monitor that carefully, weighing them twice a week, encouraging them to eat small, frequent, high-protein, high-calorie meals, and involving a dietitian. That loss of appetite is a very common occurrence in patients with cancer. It's a side effect of the cancer itself as well as from the treatment. It could be related to an inflamed mouth or esophagus, so it may be difficult for them to chew. It could be related to anxiety and depression, so there's several etiologies for it. Teaching patients the importance of oral hygiene, if they're dealing with those oral irritations is essential. Patients who are undergoing radiation especially may have a loss of taste or dysphagia. They may have to drink water frequently because of having decreased secretions. So you want to make sure you're observing for dehydration. Patients should be eating soft, non-irritating foods if they have complaints of irritation in the oral mucosa or esophageal mucosa. Skin reactions can occur in the area that's being treated, and they can be acute or chronic. Anywhere from 1 to 24 hours after treatment, they can develop. Typically, the more treatment dose, the more, of course, side effects or intensity of the skin reaction. It's important to especially assess areas of skin folds or areas that are subjected to pressure, such as behind the ear and the gluteal folds, perineum, breast, collarbone line, and bony prominences. So those are important assessment focuses for the patient undergoing treatment who is having radiation and at risk for a skin reaction. This image is dry desquamation. Typically after dry desquamation, there's going to be an acute response of erythema or redness. These dry reactions are uncomfortable. They can cause itching, so lubricating the skin with a non-irritating lotion or an aloe vera is an important intervention. And then wet desquamation occurs when the rate of the cells that are sloughing off is faster than the ability of the new epidermal cells to replace those dead cells. So that occurs, and there's exposure of the dermis, there's weeping of serous fluid, and that area has to be kept clean. It has to be kept protected from any further damage. That's a very painful situation. It doesn't look like it would be very pleasant. And there's an increased risk of infection. Anytime you have these skin reactions, the goals, of course, are to prevent infection, facilitate wound healing, protect irritated skin from temperature extremes. You don't want to have very tight garments on or use harsh chemicals or deodorants. And in the case of alopecia, you want to help patients as they're dealing with hair loss. There's an excellent program through the American Cancer Society, Look Good, Feel Better, and that's a good support and resource for people experiencing not only hair loss, but just body image changes in general. And body image changes or disturbed body image is definitely an appropriate nursing diagnosis for some of these patients. In regards to the pulmonary system, both chemotherapy and radiation have the potential to produce damage to the pulmonary tissue that is irreversible and can be progressive. Distinguishing whether it's a complication from treatment versus whether it's related to the actual disease can be difficult. And then immediate effects of radiation as far as the pulmonary system can actually be quite alarming because they mimic symptoms that caused or precipitated the cancer diagnosis in the first place. So like dry cough, dyspnea, and those types of things. Treatment would include bronchodilators, expectorants or cough suppressants, bed rest if needed, and oxygen. Cardiovascular effects of treatment. Patients who have a pre-existing disease are clearly more vulnerable. These patients may require a baseline echocardiogram and then periodic echocardiograms as well. And there is a chemotherapy-induced cardiomyopathy that can occur, so it's important to monitor these patients for any changes. Pericardial effusion is also a common finding. Cognitively, a lot of times you'll hear patients on chemo say they have chemo brain, which is what they refer to as brain fog. They have thinking problems, memory problems. Generally the brain is going to recover over time, but the effects can last anywhere from a short time frame to years. It may even cause the patient not to be able to work or participate in social activities that they are used to being involved with. And then reproductively, of course, there's going to be side effects. There's going to be the potential of fertility issues if there's not appropriate precautions in place. Those effects occur most often when the reproductive organs are that targeted area of treatment. So it's important that the patient and their partner get information about expected side effects of the treatment relative to reproductive and sexual issues, and that anything that can be done to preserve their fertility is discussed and initiated. Patients who are experiencing cancer pain should always be believed. That if they say they're in pain, they're in pain, and they should receive appropriate pain medication to help cope with that pain. Additional treatment options include immunotherapy, targeted therapies, which we mentioned in the last presentation, sex hormones and corticosteroids, bone marrow transplants, and stem cell transplants. Oncologic emergencies are life-threatening, and these are emergencies that occur as a result of either the disease itself or the treatment. These can be obstructive emergencies, metabolic, or infiltrative emergencies. Obstructive are going to generally be caused by the tumor obstructing an organ or a blood vessel. Maybe like something like spinal cord compression syndrome would be an example, or an intestinal obstruction. Metabolic emergencies are going to be caused by the production of ectopic hormones from the tumor, or either secondary to some type of alteration caused by the tumor or treatment itself. Metabolic emergencies can include the syndrome of inappropriate antidiuretic hormone secretion, hypercalcemia, septic shock. And then infiltrative emergencies occur when those malignant tumors infiltrate major organs or occur as a secondary to cancer therapy, such as cardiac tamponade and carotid artery rupture. And that concludes this section of the cancer lecture. Please write down your questions. I'm sure there's definitely when you're looking at this, I'm sure questions are going to arise about radiation and chemo, so make sure you jot those down.